Hello, thanks for joining us. Today we'll be discussing the topic of prognostication in serious illness from basics to integration of AI. If you want to hear about more topics in serious illness, please visit Puracare.online for free access. Let's get started. This presentation is for educational purposes only. It does not constitute medical advice and should not replace individualized clinical judgment. Patients should consult their healthcare provider for diagnosis and treatment. The views expressed are my own and do not represent any institution or organization. I have nothing to disclose. The session objectives for today will be to review indicators of prognosis of 1 year or less in serious illness, review available prognostication tools, and explore the current utilization of artificial intelligence in predicted outcomes for patients facing serious illness. We must recognize that there is an intersection between value-based medicine and artificial intelligence. When I put this Venn diagram together, it occurred to me that artificial intelligence and healthcare utilization optimization can meet right in the middle to enhance end-of-life care. At the end, what we're trying to achieve with good prognostication tools, including the utilization of artificial intelligence, now widely available and being studied and researched in this field, is to be able to offer the patient the opportunity to have serious illness conversations when it's adequate and is appropriate in the course of their disease, so that we can offer the appropriate care at the appropriate time for better outcomes. Those outcomes could be mostly quality of life and avoiding harm. We know that a vast majority of healthcare expenses for patients are being spent at the end of life, the last 6 months most likely. So it is important for us to be good stewards of the resources that we have, and in that sense, bring the patients the correct and the most appropriate care that would enhance their days, their weeks, months, or years that are left. So let's talk about artificial intelligence. There are different AI models. Artificial intelligence is a computer program that you code to emulate the human thinking. And there's subsets like the machine learning, where you have the machine analyze vast amount of data. And what we're seeing with this machine learning is that it's saving us time reviewing, let's say, vast amount of medical records or internet data and putting it in front of us in a record amount of time that the human could not possibly do in such a short notice. So this machine learning can be utilized in prognostication by feeding the machine an algorithm that tells us, okay, these parameters are to be looked for, and if the patient meets these criteria, the outcome will be A, B, or C. However, that is more of a supervised machine learning. There's the unsupervised machine learning, where the machine actually can learn from the feedback given to the program and start finding data that we did not necessarily think will be a pattern leading to those outcomes that we're looking at. And that's where it becomes really fascinating in helping us prognosticate more accurately, perhaps in the future. These are the things that are being looked at now in the present and slowly being utilized in certain healthcare systems. There's the deep learning, which is when there are more like neural networks involved, where the coding is a little bit more complex than just an algorithm. It allows the machine to do a whole lot of independent thinking, and it becomes a little bit difficult for us as physicians to utilize this system, especially if there's not a good interpretation of the results. By that I mean that when you are using an AI model for prognostication, you want something called interpretability. Interpretability means that when you have a result the machine has provided to you in terms of outcomes for a patient, you can look back and see why the program thought that this is the outcome. What were the parameters that were looked at? right? And what were the patterns that were looked at, so that you can feel more comfortable having this conversation with your patient and your families. There's generative AI, which is also part of that deep learning and also machine learning, but combined can also generate images. And that it's, like your latest version of ChatGPT that can generate images just by you describing what you're thinking. And again, this is getting really sophisticated. This is an example of an AI model that was created for oncology outpatient. And the issue was, that they were seeing patients having treatments that were misaligned with their goals and values. So they wanted to nudge the clinicians to have these serious illness conversations, SIC for short, and see if they could be done timely, or if they could be done more frequently, and that perhaps will reduce end-of-life care utilization. In looking at those outcomes, they did see that AI prognostication and behavioral changes for these clinicians did improve patient-centered care. So those are things that we're looking into now in the recent era of prognostication, allowing, like I showed you in that Venn diagram at the beginning, to recognize patients' potential outcomes so that the treatment can be aligned appropriately in providing better end-of-life care. This is another example predicting death and hospice outcomes in hospitalized patients with COVID-19, minimizing racial bias. One of the major concerns we have in utilizing AI is that we know that there's bias in our documentation, that there's bias in our records, in our EMRs, because we are humans putting this information into these systems. So when you have an artificial intelligence solution, you have to try to see how you can clear as much as possible that bias that's already contained in the records. In this case, the outcome predicted were a composite of hospital death, discharge to hospice, or death within 30 days. These particular tests had a good area under the curve of about 0.89, which by the way, anything above 0.87 is really strong discrimination, with a positive predictive value of 46%, more or less, which is also really strong when we talk about prognostication. And the key finding is that it provided accurate, unbiased prognostication for short-term mortality and hospice outcomes in hospitalized patients. So see that there were two different ends. You were trying to make sure that you were prognosticating accurately, but they're also trying to look into the racial bias. Something that has been done recently when AI models are being built for prognostication is that they eliminate the race as a data point, and instead they're utilizing zip codes, regions, where does the patient live, that in that case would not affect as much the outcome as race affects the outcomes of these prognostic models. So that's really interesting, and they have come to that conclusion obviously with a whole lot of study and trial and error. Prognostication tools available nowadays continue to be the famous surprise question. If you don't know what the surprise question is, you ask a clinician, would you be surprised if your patient is here for Christmas? Would you be surprised if your patient is alive in the next 12 months? And if the answer is no, that means that it is the right time to start a serious illness conversation. And these surprise question actually head to other prognostic models, like for example the Seattle heart failure model to prognosticate death. It actually compares really well. So it's something that we can continue utilizing in our day-to-day practice. Disease trajectory models that we're going to discuss today, statistical models. I'm going to be utilizing the Salpeter criteria, which she and her team, it's an old study actually from 2011, 2012, but it had a large amount of data. I wish you had AI back then to analyze this data, looking at what were the similar characteristics of patients who died within 6 months, and put that data together to help us understand who we should be looking at to have these serious conversations, because the prognosis may be 6 months or less. So I think it's really helpful still today. And there's the machine learning models that we're discussing today. there is bias in prognostication by the physicians. So this was studied and looked into, and experienced clinicians are less likely to make prognostic errors than less experienced clinicians, right? So your clinical trajectory, looking at linear a follow-up and outcomes will definitely inform your ability to prognosticate a patient's outcome. But longer duration of patient-physician relationships have been associated with greater error in predicting survival and more optimistic prognosis. So how about that, right? So the closer we grow attached to our patients, the less likely we are to see that these patients may be facing end of life. So again, when we're assessing a patient to potentially speak about end-of-life care, there's a surprise question. Would you be surprised if the patient dies within the next 12 months? If your answer is no, you think that patient may end up dying in 12 months, that could be a terminally ill patient, and that could be the moment to start talking about end-of-life care, goals of care, serious illness conversation, as we call it. There's also frequent hospitalizations due to poor psychosocial or spiritual physical health. We know that not only the physical health of a patient accounts for their increased mortality, but the psychosocial support that these patients may have is significantly important. It's not the same of a patient who's seriously ill living in the community by themselves, the patient seriously ill living in the community with loved ones that are taking care of them, or in a facility that is already providing good care. Frequent hospitalizations, especially if in the last 3 to 6 months for the same diagnosis or several comorbid conditions. Complex admissions, ICU stay, ventilatory support, need for PEG tubes, recurrent infections, all of that should make us think about that potentially limited prognosis. I promised that we're going to talk about illness trajectory. So this is your typical and traditional illness trajectory curve. Your patient with cancer will have a relatively good performance status, their ability to do their daily activities and complete their task until, they're no longer responding to a treatment or no longer have any other ability to continue cancer treatment, and then quickly decline and die. That's different from your COPD or CHFR. These patients with chronic illnesses will have the up and down, never going back to a baseline, but just very difficult to prognosticate because they bounce back each time. It's just that in time, that bounce back will be less and less, and eventually death will happen. So that can be pretty protracted. And there's the one that is just can go on and on and on for 10 years in average, your neurological diagnosis, right? Your ALS, your dementia patient has this typical trajectory of when they are diagnosed, they have a very low performance status, but they maintain that kind of low level of performance all the way until the end. And it's also because of how long that trajectory is, can be very difficult to diagnose. Now, when we look at disease trajectory in cancer, there is a change, a recent shift in how the normal cancer trajectory that we've always recognized with a steady performance status until the patient no longer is tolerating treatments or the disease has significantly advanced and there's death. Immunotherapy is changing this for many cancers. So with more than 12 immunotherapy agents today, and more to come, we have this trajectory changing to where these patients may be experiencing a little bit of a decline and dip, and then a resurfacing of perhaps improved performance status, and go on to live 4 or 5 years. For example, melanoma used to be 10 years ago a diagnosis that if you were diagnosed with a stage 4 melanoma, the prognosis was just a few months. And here we are, patients with melanoma living 5-10 years of good quality life, thanks to the many combinations of traditional chemotherapy with immunotherapy and other agents. Similar to small cell cancer, it was a death sentence with 2 to 3 months survival. And no longer we're seeing such a short prognosis for patients that tolerate other modalities of treatment, including immunotherapy. They can be living pretty much a chronic illness life and have, a prognosis of about 5 years, depending on their response. So again, immunotherapy and disease progression of the cancer is something that has changed that prognostication curve for cancers in general. And that's something to have in mind when having these conversations with patients. Now, when it comes to cancer, there are major indicators of terminal illness, such as having an advanced cancer stage 4, progressive disease, number of mets, not the same, having 1 or 2 metastases that can be locally eradicated versus having more of a disseminated metastatic disease. Certainly those patients are no longer seeking curative or disease-targeted treatments. And if there's a significant weight loss of about 10% in the last 6 months with poor nutritional status. And again, like I mentioned before, there's so many treatment modalities for cancer patients, from cytotoxic therapy to targeted therapy, immunotherapy, checkpoint inhibitors, and adjuvant interventions that the landscape's different. The prognostication has become a little bit more complex. And if we can find other alternatives of how to predict outcomes for these patients, certainly we should be looking for those. Now, which of the following is true? Immunotherapy generally results in immediate and predictable tumor reduction. Patients on immunotherapy often experience delayed tumor regression or pseudoprogression, complicating survival predictions. Favorable response to immunotherapy reduces in patients older than age 65. Well, let's start with A. Immunotherapy generally does not result in a predictable tumor reduction. It's very different and complicated for different patients. We often see that patients with lung cancer treated with immunotherapy have sort of an inflammatory response around the tumor, and these x-rays look pretty dramatic during the beginnings of the immunotherapy treatments, and that should not deter the clinician from continuing treatment as far as the patient's tolerating it. There is no say that a patient older than 65 could not respond as well as a patient younger than 65 to immunotherapy. There's actually good response in older patients, and there's more studies that need to be conducted and completed. But as of now, being older than 65 will not preclude you from starting any immunotherapy and does not render you less responsive. So the correct answer is that patients on immunotherapy often experience delayed tumor regression or pseudoprogression at times, and this complicates the survival predictions. Some AI models have been tested in the oncology world, and I just wanted to give you a couple of examples. This was from JAMA in 2022, prospective comparison of medical oncologists and machine learning model to predict 3 months mortality in patients with metastatic solid tumors. Another one, validation of a machine learning algorithm to predict 180-day mortality for outpatients with cancer. So some of these models outperform oncologists in predicting metastatic solid tumor mortality, but some did just about the same. Some models already integrated to hematological malignancy exist. For example, in Duke, I know that they're utilizing some AI models that can render relatively good prediction for patients undergoing treatment for hematologic malignancies. And again, is so that we can deliver the right care at the right time. For heart failure, end-stage prognosis, again, like I mentioned in that disease trajectory where the patients can go up and down, never going back to the baseline in terms of their performance status until they die, it can be really challenging. But Salpeter, remember that I told you that she compiled information from many publications, over 3,000, to help with prognostication with chronic or serious illness. And she put this together that a patient with heart failure, hospitalized with severe CHF exacerbation, with a New York Heart Class 3 or 4 plus 3 or more of any of these, should be considered to have a 6 months or less prognosis, or at least you should be having serious illness conversation. And these characteristics include being 70 or older, a low EF, low blood pressure, low sodium, history of cardiogenic shock, dependency on NADLs, which is a common theme on chronic illness as a predictor of poor outcome. Second hospital stay in a month or fourth hospitalization for CHF, a high BNP, high creatinine, other comorbid conditions, low albumin, or malnutrition. Let's take a look at this case. I highlighted the most relevant data so it's easier for you to follow. 76-year-old female with history of heart failure with reduced ejection fraction presents to the ER. She has dyspnea at rest, BP of 98 over 60. Recent labs show creatinine of 2.6, which the previous was 2, a sodium of 130. The echocardiogram shows an EF of 20%, that is unchanged from the last previous month. And she recently moved to an ALF due to difficulty caring for herself. She's medically optimized. She has been hospitalized 4 times in the past year for similar CHF exacerbation symptoms. Which of the following is true? This patient has advanced heart failure, however, does not have a prognosis that should lead to hospice referral at this time. Remember, hospice eligibility is that a patient should have a prognosis of 6 months or less of life if the disease continues its predicted course. Given the disease trajectory, this patient has a prognosis of less than a year if the disease continues predicted course. Serious illness conversation should be initiated. Or C, I should consult a cardiologist to help me determine the prognosis for this patient. Well, obviously the answer is B. This patient has enough data here in front of you to tell you that she is definitely facing end of life, given her serious illness, with repeated hospitalization, with signs and symptoms that are very consistent with that patient that is facing a potential mortality in the near future. And we don't have to be so scared to have these serious conversations, thinking that maybe the patient ends up living a little longer. Because what this is doing is just putting the patient in the right place with the right treatment plan for the limited prognosis, even if we undershoot or overshoot by a few months. This is important. It gives patient information that is valuable for them to make very serious decisions. There's several heart failure predicted models. The Seattle heart failure model is widely utilized in heart failure clinics. There's also the heart failure survival score, the Magellan heart failure risk score, and the MAGIC score. And again, the reason I'm mentioning these, and these are really easy for you to find online and just plug in data, is so that you will recognize that a lot of the data that these models are utilizing to collect information and determine a prognosis is the same similar data that are being fed into these algorithms for machine learning. And that's how we're getting some of this information. Plus that unsupervised learning, which is, okay, this algorithm is asking me to look for this data, but now I want to find any other patterns that I consider also are consistent with this outcome. This is the Seattle heart failure model. You can again find it online. You're going to fill in data such as demographics, age, gender. You're also going to add weight, what's the New York heart class, what's the EF, systolic blood pressure. Remember, a lot of these parameters are already discussed with Salpeter's criteria for patients potentially facing end-stage heart failure. You're going to click what medications the patient is currently taking, including diuretics, and also laboratory data. And it can give you a baseline 2-year, 5-year pre and post intervention outcome. This is an example of a deep learning model utilized to prognosticate patients with heart failure. And it was deep learning based prognostic model using non-enhanced cardiac sign MRI. That's the MRI utilized for movement as the heart is always beating, for outcome prediction in patients with heart failure. And in this study, the deep learning module used non-contrast cardiac MRI plus data from the health medical records, the EHR, to predict outcomes in patients with heart failure with reduced ejection fraction. The C index was 0.85. Earlier we discussed a C index of 0.87 or 89 is excellent or pretty good. So this is better than conventional models. Clear separation between high and low risk groups was obtained. And deep learning plus the MRI outperformed traditional risk models. So this is something to look forward to, that we could potentially have data that is already existing in the electronic medical record, coupled with recent imaging such as a sign MRI for cardiac patients, and be able to predict outcomes that sometimes are pretty hard, as I mentioned, with congestive heart failure patients. This is another study with deep learning prediction of survival in patients with heart failure using chest x-rays. So similar to the other one, the model utilized data, key predictors obtained from the EHR, including age, BNP, pulmonary artery pressures, New York Heart Class Association, and CTR. And deep learning with chest x-ray actually improves survival prediction in heart failure. Never have I ever seen this patient around. I think we have all experienced a patient with COPD who just have these recalcitrant symptoms and recurrent hospitalizations. So just your typical COPDer who's been discharged after their third COPD exacerbation in 3 months with a high CO2, requiring significant assistance with ADLs or skilled nursing home stay after that hospitalization. Salpeter criteria in that analysis tells us that a patient with COPD with a hospitalization for exacerbation with hypoxemia, hypercapnia, supplemental O2 dependence, and 3 or more of the following, similar to CHF, will have a limited prognosis considered to be in the 6-month mark. And similar to heart failure, there's the age component, 70 or older, dependence on LDL, ADLs, or having to be discharged post-hospitalization to a skilled nursing facility to regain strength, weight, and we know that patients with CHF and COPD who have lower weight tend to do worse than those that have higher weight. So it's the only time that you want to have a few extra pounds on you. Whether the patient has right-sided heart failure or cor pulmonale, repeated hospitalization due to COPD in the last 2 months, low BMI, we mentioned also intubation, ventilation, high creatinine, and albumin less than 2.5. The Bode index has been utilized to predict mortality in patients with COPD at year 2 years and 52 months. Again, it's a point system taking in consideration the FEV1, the distance walk in 6 minutes, the Disney scale, and a body mass index. And it's really not helpful in prognosticating within 6 months of death, but at least can give you an idea of how close the patient is to requiring perhaps increased support for end-of-life care. Well, similar to those Bode index factors, you can find those factors being considered in some AI models that are being studied. For example, this deep learning prediction of survival in patients with chronic pulmonary obstructive disease using chest x-ray. So the model considers chest x-rays, results, age, BMI, and FEV1. And this tool performed better in predicting 5-year survival compared to traditional clinical indices, for example, like the Bode. So again, that machine learning and deep learning combined, where you can feed this system images and also data points that can give you an outcome. Just fascinating. For liver disease, the end-stage indicators that Salpeter has recognized before included decompensated cirrhosis or a patient who has a MELD score of 21 or greater. Remembering MELD score is the model for end-stage liver disease, highly utilized to stratify patients for hepatic transplants. And Salpeter says that a patient with hepatic cirrhosis with a hospitalization for acute illness related to liver disease and one or more of the following presentations, plus a MELD score maybe a little lower, in this case she says 18 or greater, who presents with evidence of hepatorenal syndrome, ICU stay, or is already dependent on 3 ADLs or more, we know that they also have a very limited prognosis. This model that was researched in 2021 shows predicted mortality among patients with liver cirrhosis in electronic health records with machine learning. So this was just scouring data from the EHR to predict mortality for these patients. And 3 windows of mortalities were identified: 365 days, 180, and 90. It utilized machine learning and deep learning. It outperformed the MELD score and the MELD 4 variable versus 41 clinical variables. So that's the fascinating part, because the machine not only identified the variables that were in the MELD score, but went on to identify a total of 41 different variables to produce an outcome for these patients. That would be very difficult for us to do it in real time without the assistance of a more sophisticated program. Now let's go to renal disease and prognostication. Salpeter says in her paper that patients who decide not to continue dialysis or have not undergone dialysis and are 70 or older with one or of the following: dialysis is withheld due to decreased performance status, or dialysis is withdrawn due to advanced age, functional dependency, or comorbid conditions. These patients definitely have a 6 months or less prognosis. We know that dialysis patients and renal patients are the least to receive end-of-life care with hospice, at a tune of maybe 2% for only an average stay of 3 to 4 days. Survival after stopping hemodialysis averages about 7.4 days. So this is critical. Maybe we should have better ways to identify these patients before getting to that very last few days of life, so they can benefit from programs that can enhance their quality of life. Some indicators for patients who are currently on dialysis in age 70 or older, who have 2 or more of these findings. Again, dependence on ADL is a big one, activities of daily living, significant comorbid conditions, admissions to ICU for acute illness, malnutrition, a factor that's really important in renal disease, patients being residents in a skilled nursing facility, or recent hip fracture. This prognostic tool for end-stage renal disease patients with chronic hemodialysis is a really good risk assessment, and is a prognostic nutritional index. And it has a cutoff value of about 42.3. And the higher this PNI, prognostic nutritional index, the less mortality in hemodialysis. So you want to have a high PNI, not a low PNI. It's easy to calculate. You can go to your preferred, Gemini or ChatGPT and calculate the PNI for this patient and just give the parameters, right? The parameters are serum albumin and total lymphocyte count. So we know that PNI of 45 or greater is a good prognosis, and a PNI of 40-45 is moderate risk, where a PNI of less than 40 carries a higher mortality. So this particular model was a machine learning model to predict 1 to 3 years mortality in patients on hemodialysis. It was an observational study, and 800 chronic hemodialysis patients participated, and the data from 44 lab indicators was collected. And the key factors were inflammation and nutrition. So again, going back to the previous slide, we recognize that the PNI has been studied as a very good predictive factor for mortality, and such data now being integrated into these machine learning models, right? So look at these now, how we can understand the background of where this data is gathered to inform studying machine learning devices, right? So here's a little challenge that I actually followed in the community, a patient with these characteristics and these findings, and I wanted to share with you. She was a 40-year-old female who tried dialysis and discontinued after 3 months with a GFR of 7. Her primary diagnosis is congenital urethral reflux without any other major comorbid conditions, other than perhaps an under or not diagnosed bipolar disorder. Her phosphorus was 5.6, a little high, albumin 3.5, potassium 4.5, both okay, and lymphocyte count of 4,800, okay. Her calculated PNI is 59, which is good. Her predominant symptoms are nausea and generalized pain, which actually we had to adjust the medication quite often because of that. And her palliative performance status about 60%. So she was still ambulatory, able to take breaks during the day and do her own thing, occasionally leave the house, but overall a little challenge due to fatigue. So what do you think would be the prognosis for this patient? This patient actually was under hospice care for over a year, with multiple discussions whether she should continue under hospice care or be discharged. By all intents and purposes, she met all the criteria to be under hospice care with a very low GFR, which would anticipate a very poor prognosis. But she is young. She's had renal insufficiency for most of her life, and somehow she has managed to find this stable status in her electrolyte and humerus values that have allowed her to continue reasonable quality of life and length of life. You can see that her potassium is not significantly affected, and the phosphorus was affected if we had to put her in a calcium binder and a phosphorus binder, I'm sorry. But when you see the overall status, you say that is pretty darn good for somebody with such a low GFR. So most of these prognostic indicators will have not predicted this patient very prolonged prognosis, except for the PNI, because she does have a rather good nutritional status overall with good lymphocyte count, and that PNI happens to be on the higher side. For terminal illness indicators on HIV patients and AIDS, we know that a low CD4 count with persistent high viral loads despite medications or without medications, a Karnofsky scale of 50% or less, that's again a performance status of 50% or less, which is getting around the house, doing your own thing, but having to take a lot of breaks, fatigue, and any HIV-associated illness that, per salpeter criteria, would render a prognosis of 6 months or less. This machine learning based prediction of mortality risk in AIDS patients with comorbid common AIDS-related disease or symptoms was able to identify 8 different predictors, and with pretty close outcomes, so good predictive factors. And these predictors were hemoglobin, infection pathways, use of Bactrim, expectoration, headache, persistent diarrhea, pneumocystic pneumonia, bacterial pneumonia, all of those being high critical factors predicting mortality within 6 months. So I just want you to recognize that these are potential factors that the machine learning help identify, because it can really process a lot of data and sometimes bring to our attention things that we have not necessarily factored in. We mentioned before how challenging Alzheimer's dementia can be, especially in prognostication because of the long duration, but some patients may last a little longer, some patients may last a little less time. But in general, for predicting Alzheimer's dementia, patients with advanced dementia, with losing, that are already in a stage that they're losing their words, maybe 6 words or less in a day, or nonsensical, ambulating but high risk for falls, or have become non-ambulatory, plus any compromised nutrition with significant weight loss, low albumin, recent hospitalizations for infections or pneumonia or hip fractures, and frequent falls are considered to be in that end stage and, end of life. That will be a patient that should be referred for hospice. Now look at these interesting factors, and this was studied back in 2000s. 6-month mortality for patients with end-stage dementia, how they differ from a patients the same age who are cognitively intact. If a patient with end-stage dementia has pneumonia or is admitted for pneumonia, has a 53% mortality compared to 13% with a similar cohort of cognitively intact patients. Same for hip fracture, about 55% compared to 12%. So those patients you normally will see in the hospital will be admitting on your service, and I want you to really pay attention to the overall condition of the patient, the factors before coming into the hospital, so that you can start having those serious conversations. We utilize the Mitchell Index to predict 6 months mortality for patients with advanced dementia, but it has only been validated for patients who are in nursing facilities. And again, it's going to ask you about age and some other comorbid factors and symptoms to determine the potential prognosis. This AI predicting tool was studied here and published in 2025. Predicting mortality risk in Alzheimer's disease with machine learning based on lifestyle and physical activity. It incorporated lifestyle and physical activity, which enables better risk stratification and targeted interventions. And but again, further external validation needed for diverse population. So it's kind of rather what I would say incomplete study, but a good start in looking at potential factors for mortality. And what I want to say is that this particular algorithm and machine learning was not great in predicting mortality, and there's more that needs to be looked into for dementia patients. There was another one, development and validation of deep learning algorithms in mortality prediction in selecting patients with dementia for earlier palliative care interventions. And this study found with machine learning that there were certain topics associated with 6 months and 1 year, 2-year mortality in patients with dementia, including this long list, cognitive function, delirium, nutritional status, arthritis, shock, respiratory failure, and dysphagia, amongst others. But again, not a great tool, not a great predictive tool. More needs to be looked into. Again, Alzheimer's being a very hard to predict mortality. I wanted to mention sepsis, especially for hospitalized patients. We have numerous tools. The hospitals are very invested in early recognition because of the CMS punitive approach. If these sepsis parameters are not contained and these patients die in the hospital. So this particular tool is an FDA authorized AI machine learning tool for sepsis prediction. It was developed and validated and implemented for Epic EMR, and they have their proprietary algorithm. And it was trained in about 2,300 admissions and also validated externally with an area under the curve of 0.81. It's good, not excellent. A really good one will be 0.87 or more. So again, these tools are being implemented in EMRs with the restriction that they're not shareable. So it can be used in Epic, but maybe the Cerner user would not have access to this. And this brings me to this point that there's difficulty implementing AI prognostic tools in EMRs. because an AI solutions are tailored to specific electronic medical record systems. There's proprietary rights which are guarded. There's cost involved in all these, in researching these tools and applying them. And there's also the liability piece. Many of us ask, well, would I have a job here in a few years? Well, until a healthcare system is ready to assume the liability of a machine predictor, they're always going to be looking into the clinician's expert opinion in final signature in anything that is an outcome predicted by a machine. So far, I still have work that we can do, and that patient-physician at the bedside collaboration, it will be very hard to be substituted by any machine learning module. I wanted to share with you that there are other prognostic tools. If you're not familiar with ePrognosis, it's very easy to access online. It's developed at the UCSF campus, University of California, San Francisco, and these models are validated, and they are divided depending on the category of where your patient may be, whether it's in the clinic or living at home or a nursing home, or whether you want prognostic tools for a hospitalized patient or a hospice and palliative care patient. And by now, at least 50% of us clinicians have access. Open evidence is for providers who have an NPI, so that you can sign up. You can even earn CME with this. It's an offshoot of OpenAI, developed specifically for clinical use. And they are very clear that they are not a prognostic tool, but I find it very helpful when we're talking about prognostication, because you can search certain topics. It can summarize what it has found, but it can also cite the articles, and you can click and then go to PubMed and be taken to PubMed and look at the article. And now they have collaboration with the New England Journal and JAMA to have the full article available for you. So it's a fantastic tool. For example, in this case, I asked, what is the prognosis of a patient with a diagnosis of a pancreatic cancer, has bowel obstruction, and is currently on parenteral nutrition? So it gives me kind of a summary of what has researched, and it gives me the different articles cited for this research, which I will review, because there is such thing as hallucination when it comes to AI tools. These machine learning systems can talk to you about something completely unrelated to what you were asking, or perhaps at times bring false information. Remember, it's feeding out of the entire internet. But this tool just happens to be really nice, very well refined, I would say. And the fact that you can go to the reference, which I always do, and try to click on one or two to see the abstract at least, and if I have more time, then perhaps read most of the article. There's certain things we need to keep in mind when engaging with AI tools. Interpretability, understanding the process is important, so that whatever information this tool is giving us could be interpreted. We can actually ask, what were the parameters utilized to give us this final outcome. Make sure that the data sets are diverse, so there's less bias. It's important that your institution has guardrails around AI utilization and EMR data collection, patient information privacy. And the expectation is to utilize this tool not as a final solution. You cannot turn your brain off. This is just an extra helpful tool, right? I often find that it just brings at times information in front of me that I may have not thought about, and that makes it very valuable. Now, I wouldn't want to finish this talk without going over some rules when communicating prognosis to patients and families, because we may have this information at hand, but sometimes it's very difficult to deliver it. So we advise not to give a specific number. So when you're talking about prognostication, talk about days to weeks, weeks to months, months to years. Discuss prognosis in terms of uncertainty. Be open that this may be the case, but we have to be realistic, and some may surprise us because they die sooner, and some may surprise us because they live longer. And always have the rainy day thinking, hope for the best and prepare for the worst. Because we're here not to take hope away from people. We're here to inform them and empower them with information. And there may be the spiritual magic thinking that, that mom's going to get better because I'm praying really hard and my prayers are going to be heard. That is very particular for that patient and family, and it's part of their belief system, and it's not for you to take away. You're just giving them information and they are processing it. You'll be surprised how much of this information is processed. It's not that they're tuning you out. It's that it's important for them to affirm their beliefs despite of what you're saying. And you're there just to listen and to support. So in conclusion, predicting death can be challenging. Utilization of available tools can improve your prognostication average. AI can be helpful in identifying high-risk patients and opening the doors to serious illness conversations. And interpretability should be the feature of any tool assisting with medical prognostication. I want to thank you for staying tuned. I hope that you were able to get some good information or reaffirm your knowledge in AI and prognostication. Feel free to share these with your friends. It makes me happy to know that we have this free access to this important information for anyone to learn. Have a great day.